This is One in Five, a podcast from Providence about disability and the intersections with healthcare. On today's program, does disability make me a better caregiver? I'm Sarah Quinto.
And I'm Angela Marith. We're delighted to welcome Dr. Carrie Fathke to the podcast. Dr. Fathke is a family medicine trained hospital medicine physician and is the Chief Medical Informatics Officer at Providence for Patient Care Logistics and the Texas-New Mexico region. Welcome to One in Five, Dr. Fathke.
Thank you. I'm so excited to be here today and have this conversation.
Can you share a little bit with us about your connection to disability?
In 2015, and my daughter Cleo was born with, at the time, a very rare, unrecognized genetic disease called NGLI1 deficiency. These kids are usually diagnosed by the age 5 if they have access to the right healthcare system. They have a seizure disorder, usually a complex seizure disorder. They have issues with walking. They have issues with speech development. They have issues with fine motor control. They have cognitive delay. They have issues with gut motility, with nutrition. So it's like it globally affects their neurological system. It seems to be progressive, and it can be very debilitating. There's various different kind of what we call phenotypes, meaning not every kid with NGLI1 deficiency looks exactly the same, but they all have some very common characteristics.
I'm wondering if you could say more about how you as a physician balanced those conversations that you needed to be having with medical providers while at the same time thinking, I have a child, I'm raising a child. I don't want to spend all my time in doctor's appointments. What is going on? I'm curious if you could say more about that, just, being a practitioner yourself.
To be honest, I was, and it's still sometimes it's messy emotionally and cognitively for me. And the reason it's messy is because I also know my colleagues and the nursing and how hard it is to do the job. I also know from the other side, through parenting communities, how hard it is to be a parent who feels listened to. And so navigating that line to me is complex because I hold two different worlds inside, and I'm always worried that I'm leaning one way or the other too much and doing Cleo a disservice, right? Just to back up. So before I became a chief medical informatics officer, I was a chief hospitalist at Swedish's Heart and Vascular and Neurosciences Institute Hospital. So I worked with really complex sick patients. I was chief of staff of that hospital and have had a lot of years of experience. And I just remember one time when no one was listening to me going, how trained do I have to be to have these physicians in front of me just stop and listen? What do you need me to tell you to say, I need you to just stop and hear me? I might be wrong, but what I get from you is that you're not understanding what I'm telling you. And I was like, how much more expert do I need to be? I'm an expert for my child. I'm an expert in a lot of things in medicine. I was like, I just remember breaking down, and feel like crying to the pulmonologist. I was like, I don't understand. How much more do I have to feed the information for them to you? I was like, can I just run? Can I just take care of her myself? Just let me know. I'll put the orders in. I'll let the nurses do it. Just like you guys, and again, I was in this space where I was like, what if I didn't have this knowledge and I was a parent trying to advocate for my child and didn't have this language? And it was just so frustrating to me. And that's really changed my perspective as a physician.
I want to talk a little bit more about that because you are a physician You went through medical school. You did your residency. You've had some very important jobs. You have a lot of subject matter expertise. You also are the parent to this daughter, and you have experienced people not listening and disbelieving what you have to say. And so can you talk a little bit about, you had mentioned when she was hospitalized one time, and then you started talking about this like being disbelieved. Can you tell us like what happened in that specific instance?
Oh yeah. Yeah, exactly. So the situation is with Cleo is that when she sometimes in the past, when she had a lot of problems with nutrition before we got her feeding tube, she was really susceptible to viral illnesses. So it was a problem of ventilation, right? She couldn't, her muscles and her nervous system were so weak and discoordinated that she couldn't, ventilate well, meaning get rid of that CO2. Well, it's when patients come to the hospital with breathing issues, the most likely thing for a team to think about are oxygenation issues. Like, can you get enough oxygen in? But the lungs have two different sorts of like things that they do. They breathe oxygen in and they expel CO2 as a waste. The breathing oxygenation in kind of requires your muscles to fully expand, to kind of open up the lungs and oxygenate all the blood. But to do the CO2 part, you have to really be able to exhale and kind of get rid of all that buildup of waste, right?
Okay.
She was, so there wasn't a problem with her oxygenation. It was purely a problem with her ventilation when she was in the hospital. She had neurological problems that didn't allow her to do that oxygen and CO2 exchange really well. I'm going into this because like it's something that catches like every physician, even in like the neuroscience hospital that I work at. Like we focus so much on these oxygenation numbers that we can see that we don't focus on something like ventilation, which is harder to measure. And Cleo wasn't doing well. She was like, her oxygenation looked perfect. They were wanting to like wean her and discharge her. Meanwhile, her heart rate was through the roof, like, which, and she was cognitively not herself. She was lethargic and sleeping all the time, which is not her. She's like an active kid who's chatty and like, she was so tired and fatigued that she didn't even want to watch her iPad with My Little Ponies, which she is obsessed with, right? Obsessed with.
Definitely a sign.
Right. And I kept telling the group, I was like, look, I hear that her oxygenation is good, but you're ignoring her heart rate. You're ignoring the fact that she's not waking up. You're ignoring the fact that she doesn't want to eat. She's not having normal bowel movement. She's not urinating. I was like, this is telling you that something's wrong. And you're anchoring on this oxygen number, which looks fine to you. And you're missing the forest for the trees, man. And so that was the situation we were in, and they just couldn't hear it. Part of it was a busy time in the hospital. There was a lot of viral illness. The hospital was full. There's a team of residents, and it was the interns, which I totally understand. I was an intern. I know how challenging that situation can be in, but the intern just couldn't understand what I was telling. And then when present to the rest of the team information, I was there and I was like, you're missing the point. Like when I was telling you that you needed to get this from it. So it was this weird space where I'm like, I've been an attending, I've taught residents, I've taught fellows. So there was an attending on the rounds. It was just like this crazy moment where I'm just like, I'm trying to teach you, I'm trying to advocate for my daughter, and I still am not hearing that you're understanding. And that really, I was just like, I need to see the pulmonologist. Like, I was like, I can't deal with this anymore. Can you have the pulmonology fellow come and talk to me? And I just felt like a jerk. And I'm sure the resentment was rolling off of me, and I'm sure the team picked up on that, which created this tension. Which was probably not in Cleo's best interest, but I was just tired of it. I was just tired. I was tired. It was like day 10 in the hospital. You can't sleep at night, all the things that patients and their advocates experience, I was experiencing too. And just, fortunately I got the pulmonologist in there who understood what I was saying, helped work through it with the primary team, because that pulmonologist, great person, great physician, she just had the connection with the team that they could trust. And then we got it done.
Was there any indication to you that the team was disregarding the significance of your daughter's behavior because of her disability?
Yeah, I think people assumed when they see Cleo's physical disability and cognitive disability that this is just how she is.
Yeah.
To be honest, like before I really had training, I can see, and living day to day with Cleo, I can see how a clinician, a physician, APC who doesn't have experience with these kids or their parents can have that bias. Like, again, it was something I was struggling with. I was like, well, and I saw this in my patients when I was a physician, and I understood that tension, which is like, this is not how she normally is. Whether it's a daughter advocating for her mother who is sick in the hospital, whether it's a parent advocating for their child, this is not how she normally functions.
I've heard that theme a lot too, in talking with different people with disabilities, so clinicians, when somebody says, my child, my mother, my, person that I know really well is not behaving as they normally do, and I'm concerned, like that is something to call attention to. And like, let's be creative. Let's look beyond, the normal step 1, 2, 3 that we implement.
Yeah, I found for me personally, and I think this is valuable for other people, is like to maybe show pictures and film, like what is a day in a life of usual function look like? Because sometimes it's really hard for a clinician to understand, what normal looks like for that person. There's so many reasons that somebody can have a disability, and it doesn't always look the same from person to person. And so I actually found taking pictures of Cleo when she's at her best, and so having videos so people understand who Cleo is as a person, has helped me kind of communicate visually what I couldn't in words.
Help us understand, I've heard, I'm trying to picture Cleo in my head right now. And I've heard you describe a whole laundry list of symptoms, which make me go, oh man, this must be really challenging. But then you also are talking about how she's really chatty and, it has so much joy and, so help me understand, like if I were to meet Cleo, what would I be seeing?
So she is charming. I think she figured out early on that certain patterns of behavior got her what she wanted.
Good for her.
It's really interesting. So she has cognitive delays by all the usual tests, but the girl can figure out which episode of there's 8 seasons of My Little Ponies, and each episode is 40 longs, and there's 20 episodes per season, right? And there's a lot of seasons to go through on Netflix, but she knows exactly which season, which part, and how to manage Netflix to get to the part that she wants to watch. And it's not always the whole program. It's parts of the program that she delights in, that make her laugh, that make her cry, that make her feel something. And she goes and she'll watch those parts over and over again without any assistance from me. And she taught herself how to do that. That wasn't me teaching her, you need to go to this and do this thing. I would show her something, and she figured out how to take it from there to kind of do the thing that she wanted. So when I think it's this whole experience has taught me well, maybe our whole perception of what cognitive growth is a little bit off. She'll go and have these tests every 6 months, and they'll ask her if she can bang something on the table. I was like, well, she's not 6 months anymore. She's 8 and 9. What 8 and 9-year-old? Yeah, they would bang something on the table, but she's like, why would you want me to do that? I don't understand.
The table, but I don't bang on the table. Right?
Like,
Yeah.
right. Like as somebody who like is neurotypical, like if someone asked me to bang on the table, I'd be like, why do you want me to do that? And like, they would tell me and I'm like, okay, I'll bang on the table. Like, she doesn't have the ability to say, why do you want me to do that? She just gives you this like, what you talking about, Willis? Look, like what? This is so uninteresting to me. And like, this is not getting me anything close to what I want. I don't care, is like what her whole kind of like attitude is. And she conveys a lot by sounds, articulating the sound and tone of her voice. She communicates a lot by gestures. Like, I know she wants me to cuddle with her, is that she'll get on the couch, she'll reach for the blanket, which means she wants me to put the blanket on her. Then she'll look at me with a very intent purpose, like, and I know that and means she wants me to sit by her. She's trained me really well over the years. So I sit by her, and then she, if I don't have my like iPad or like device in front of me, she looks around for it, because she knows if I'm sitting there with that device, either reading on my Kindle or something, that I will stay there for a while. So she looks around for it, and she finds it, and she hands it to me, because that's her way of saying, I need you here, and I need you to be with me for a little while. And I think about this, like, I follow a lot of parents on Instagram with children with various degrees of disabilities, from some that can't move at all to some that can move, and have autism and need to express themselves in different ways. Like, parents really know their kids. And they know like what their kids are trying to communicate. They know what makes their kids happy. Those kids have a rich inner life that we may not be able to measure by our usual standards tests, but it's true. You look at all the comments, and all the comments are like, oh, mom just wants to be this, or dad just wants them to think that. But no, the reality is they have a very rich inner life, and they work around their disabilities to communicate and build bonds with the people around them.
What's coming up for me is this idea in hospital settings, in medical settings, of interpreters. We're interpreting language that people speak, but we don't always think about the other types of language that people are using. These sorts of other signals that we're using to communicate. And for your daughter, it sounds like she has a very developed, rich way of communicating that maybe a practitioner doesn't necessarily recognize, and needs your translation to be able to see. And it doesn't get looked at. It gets overlooked. It gets dismissed. It gets underplayed. And then additionally, you have that inner dialogue, like, am I seeing it right? Am I seeing it from the objective point of view or the subjective point of view? And what's the boundary there? What is objective and what is subjective? It sounds both difficult, but it also sounds really, there's this sort of wonderful joy that you have when you're talking about your daughter too. Like, it doesn't sound, people think of disabilities being so sad, and,
right.
So challenging, and it's also hard. And yes, it's all those things, but I also, the like subtleties with which you're describing her, and just the love that you're using, the love language that you're using as you describe her. Can we put a pin in that and just amplify that a little bit?
Even before I went to medical school, so I went to medical school as an older adult. Like, I was 28 when I started, but even before that, like, I was really interested in like the human experience and philosophy and kind of the life of the mind, if you will. I was very curious, like, how does a person think, and what is this world that we're living in? Like, why does the sun rise? Like, this, like, kind of very philosophical, metaphysical ways of thinking, right? When I had Cleo and watched her for a while, I was like, you're right. Language is not just words. Matter of fact, words are kind of and I did some research on this, words are actually the most primitive form of communication in some ways.
And I'm wondering, what do you want for Cleo when it comes to receiving care that's different from what she's getting right now?
it's going to take me to, I need to tell another story about the time during COVID. So I was in the hospital in COVID. I was chief of staff or chief hospitalist during that time. I forgot which it was. And we had an adult with a cognitive disability. And it was at the time that you couldn't have visitors. Or I think about our patients with dementia too, where they're scared, they're overwhelmed, they may not understand what's going on, and their person isn't there for them. So what I would love our health system to understand is that people with disabilities, especially cognitive disabilities, they have people, and those people anchor them. And when those people aren't there, they're not anchored, whoever those people are to them. And those people who anchor them know them really, really well. And so there may not be a recipe book. There may not be any guidelines on how to care for these kids, and these people sometimes. But there are people who know those people well and can tell you what they're feeling. And I know it's hard to translate. I so know it's hard to translate into reassurance and into clinical care. Sometimes I just needed a physician to say to me, look, everything is metabolically okay. What I think is going to do is it's just going to be a really long recovery here. What would take you 2 to 3 days to recover is going to take you a week or two. And here's how we're going to monitor that. That's words that I've started to use in my practice. You had a stroke. You have this it's a brain injury. It's as if you had an accident and hit your head.
Right.
Here's what the next 1 to 2 days are going to look like for you or your loved one. Here's what the next month to 2 months. But here's where you might have challenges down the road. But this is kind of what that normal trajectory looks like. And if you're not in that normal trajectory, then we can address it. But I want to kind of give you this understanding and expectation so that you don't worry and stress out about things that are going to gradually change for you that I know that are going to happen. I just wanted somebody to kind of hear that, or look, I know, gosh, her heart rate is really high. I totally agree with you. Gosh, she isn't as cognitive. I don't think we have control over what's happening here. Let us think through it together. What other things are you noticing? Let's tweak some things. Let's not kind of feel compelled to close it and send it on.
What I don't hear you saying is, healthcare team, help me figure out how to cure her. What I hear you saying is, healthcare team, help me figure out how to give her the best life.
Yeah. I definitely have taken care and putting on my doctor hat on enough people and patients to understand that sometimes it's living with and not curing is where you need to go. And it's actually not a bad thing. There are cancers that used to kill you that now you just live with. And it's managing any other disease. And to me, that's okay, as long as quality of life is good. And that we're focused on this person's quality of life. How do we help them be the best human that they want to be? How do we help them be the thing that they want to be for themselves and live the life that they want to live for themselves? As a physician, that's not, my job is not to decide what that is. My job is to decide how do I align myself with you to help you do that. And there's some conversations we may just have to have, which is there won't be any not living with this disease. There will always be living with this disease. But what does that look like? And how do we get you to the things that make you feel happy and do the things that you want to do?
Is that pretty radical? I feel like our healthcare system is based on, I'm going to go to you and tell you what my issue is and you're going to help me fix it. So is that a radical way of thinking now? I want to help you live the life that you want to live.
I think it's less radical than it used to be. Like, clearly in my training, like, what has become important over time is exposing young medical students and physicians to what it means to live life with a disability or a chronic illness that isn't curable. Or maybe an illness that is curable, but you'll live with symptoms for a long time. Actually, having conversations like this, really it made me think a little bit about, well, what is the purpose of a healthcare system? And I think it kind of actually comes to me about going back to that disability concept, which is we're either preventing disability from happening, managing disability as it happens, or manage the consequences of disability over a long time.
It's been wonderful spending time with you, Dr. Fathke. Thank you for joining us today. Dr. Fathke is a family medicine trained hospital medicine physician and is the Chief Medical Informatics Officer at Providence for Patient Care Logistics and the Texas, New Mexico region. Thanks too to our colleagues Scott Acord, Sean Collins, Deepak Sadagopan, and the Disability Caregiver Resource Group at Providence. I'm Sarah Quinto.
Sarah, thank you for being by my side for this podcast. I've learned so much from you, and I'm just completely grateful. I want to thank all of our listeners for joining us, and I want to leave everyone with this to ponder as we all move in our journeys of becoming more responsible to the people around us, people with disabilities, people that don't have disabilities. We don't just accommodate and include people with disabilities because it helps everyone, although it does. We don't just accommodate and include people with disabilities because it's the right thing to do, although it is. We accommodate and include people with disabilities because people with disabilities have independent value to the collection of our global experience. Maybe those people that are different from us, that don't have what others do, maybe they don't need pity. Maybe instead we tap into disability talents and we become stronger for it. Thanks for listening today. This is 1 in 5.